Good morning and welcome to Primetime. Primetime is a Bethel Library program that is a collaboration between the Friends of the BU Library, Academic Affairs, and other offices on campus that celebrates learning in and beyond the classroom of Bethel faculty, students, and staff. Thank you for joining us today. Coming up on May 11th, Nick Zymot, Director of Field Education and Assistant Professor of Social Work, will show how junior social work students were placed in BIPOC community agencies as part of a social work pilot in community engaged learning. My name is Dr. Jessica Samons, and I am the coordinator for the Healthcare Endorsement. Today, I have 4 students, Natalie Arntson, Mikayla Turek, Abby Gessesse, and Rylie Perkins, who will be showcasing their final research projects as part of the fulfillment for the Healthcare Endorsement. These students have worked over the past 4 years of their educational experience to try to understand the healthcare industry from the inside out. The Healthcare Endorsement provides a pathway for students in all majors to learn a little bit more about the healthcare industry, from understanding how it works, to the technical sides, to the human experiences that are being lived in our patients and clients. According to the U.S. Bureau of Labor Statistics, healthcare growth is going to be 13% from 2021 to 2031, with an increase of over 2 million jobs during the next decade. In the Healthcare Endorsement, we believe that it's important for all students, regardless of their major, to have some experience in understanding the healthcare world, as there is a good probability that they will end up in a career where healthcare will be at the forefront of what it is that they're doing. Additionally, with this endorsement, we offer 10 internships that each come with a $5,000 stipend each year during spring and summer. So this is a great opportunity for students to be able to learn more about the healthcare industry, working in startups, and really getting to understand what it means to be part of the healthcare world. As we have each of our different presenters, I will go ahead and introduce them and their major, and then turn it over as they talk a little bit about their experience. First up is going to be Rylie Perkins, who is a community health major.
I'm Rylie Perkins, and I'm going to talk to you about my healthcare endorsement. So we're going to start with what is community health. It's the approach for improving health, preventing disease, reducing health disparities through addressing social determinants of health in a defined population. Public health is a set or organized interdisciplinary efforts to protect, promote, or restore public health. Community health terminology. The purpose of creating a vocabulary that's used in just the medical field is so that all medical professionals have a standard set of terminology. Some I'm going to highlight are health information literacy, and this is the degree to which one has the ability to find, understand, and utilize health information and services to make decisions for themselves and others. Community health assessment is regularly and systematically collecting, analyzing, and making available information about health community, including statistics on health and community needs. Health promotion is the process of enabling increased control over improving one's health. Some of my personal outcomes of studying healthcare, my perspective has completely changed. I've been able to learn about the many people that are in debt to the healthcare system and learn about the realistic percentage of people that are actually benefiting from the healthcare system. We've been able to highlight issues within providers, learning about the literacy gap and how much it affects people's abilities to understand what is being told to them and be able to incorporate it into their practice. My passion has changed. I feel very called to be able to help people who are being missed. And within my faith, Galatians 6:2 says, "Carry each other's burdens, and in the way you will fulfill the law of Christ." And this one is speaking to just the ability that we are not meant to do life alone. We need the love and care of others the same way we need it from other people. Jesus also cared deeply for the poor and the oppressed by healing the sick, giving sight to the blind, and a long list of other things. Things that I've learned in studying healthcare, we've talked a lot about health disparities and the socioeconomic characteristics that follow with that. We've talked about underserved populations and different ways that we as healthcare professionals can work to serve them, implement theories within our systems. The funding system, we've talked a lot about how the money flows through the system and people that are in debt to the healthcare system. We're learning about health campaigns. I have now the ability to evaluate all perspectives and complications that go into creating a health campaign or promotion. I'm able to identify a target goal and collaborate with others to meet the goal. Some specific skills that I've taken away are an understanding of the healthcare system. My personal communication skills have increased. I've been able to communicate with professionals, perform interviews, and create relationships within the system. I've had in-clinic experience at my internship, which is giving me a lot of patient interaction. Ability to evaluate health literature. This is really important within this field because we have to be able to find high quality, scholarly, peer-reviewed journals and studies. I've gained skills to collaborate and be a part of a team within my internship and within group presentations. I've also gained a strong sense of empathy, adaptability, and flexibility. Some current issues I wanted to highlight within the healthcare system are addressing health disparities. We are looking at this from an equity standpoint, from the nation's overall health, economic prosperity, and the population is becoming increasingly more diverse, so this is not an issue that's necessarily going to resolve itself. The mental health crisis in the U.S., 9 in 10 adults believe there is a current mental health crisis. Over 50 million adults, American adults, were experiencing a mental illness, and over half of which do not seek treatment. 1 in 10 youth are experiencing depression that is severely impairing their ability to function, and there is an estimated 350 individuals for every 1 mental health provider. So we're seeing a really big gap in this crisis. Cardiovascular disease accounts for 28% of deaths globally, and this is highlighted because most of these diseases that are occurring can be prevented by addressing modifiable risk factors. Road injuries are similar. Interventions like helmets and speed limits, discouraging impaired driving, are all factors that we should be taking into consideration. Road injuries for people 14 to 49 is the leading cause of death. Inefficiencies within the healthcare system, like preventable medical errors. A recent study by Johns Hopkins analyzed medical death rate over a span of 8 years, found the medical errors are to blame for 250,000 deaths per year, and that makes up almost 10% of U.S. deaths yearly. This leads to hospital readmissions and takes away time and resources, which will result in inefficiency. Over-ordering supplies and throwing away unused material. Poor coordination when switching to care. Re-administration and avoidable complications increase national healthcare costs between $25 billion to $45 billion each year. High costs of care. Spending reached $3.18 trillion in 2019 and is predicted to reach $6.19 trillion in 2028. The cost compared globally, international comparison of health prices reported that every drug and procedure across 9 countries were substantially more in the United States. There is an increase in staff shortages in the healthcare system because the demand for healthcare is increasing. A lot of practicing doctors are retiring or are switching career paths due to burnout. Lack of insurance coverage is another big issue within our system. 27.5 million people are uninsured. The Affordable Care Act, put in place by the Obama administration, serves 16.3 million people, Hispanic and Native Americans suffer at the highest rate. 6 in 10 people are people of color. Lack of transparency within the healthcare system. There's a tug of war between the providers and insurance companies. Providers may upcode a procedure to get more money from insurance, but insurance may change to higher premiums, leaving the consumers in the middle. So my internship that I did this past spring was at Trust in Us Drug and Alcohol Testing. We offer drug and alcohol testing, DNA services, fingerprinting, and on-site collections. Preventative care was our main practice here. We are ensuring that employers and other drivers are drug-free. It benefits the general population, employees and employers, keeping everybody safe within the business. It promotes a substance-free life and avoiding accidents on the road and within the workplace. The community that we served was anybody who needed our services. There was only one barrier, which would be the cost of the test, most of which are ordered by your employers or courts. Our community was very diverse. Like I said, we served anybody and everybody, so this really allowed me to broaden my cultural lens. Almost every day I was speaking some form of Spanish, trying to help patients come in and understand what is being asked of them and why they're being drug tested. I also used a lot of body language, hand motions, walking people to where they needed to be. There's a variety of emotions that walk through the door. A lot of people are confused or don't necessarily understand what's going on, or they are angry or irritated about having to be at a drug and alcohol testing center. Trust in Us has partnerships, and these are companies that hire us on long-term to do their pre-employments and randoms. These are we regularly send employees to get tested. The takeaways from my internship, I got to work in a clinic setting, so I was having direct patient care, dealing with different personalities and attitudes. I got to understand the workflow within a clinic setting, and I was problem solving on a daily basis, whether it be with technology, patients, coworkers, anything like that. My cultural lens, like I was saying, has really broadened. I have learned how to communicate with other languages and ethnicities. And then cultural practices and norms were also a big thing at Trust in Us. Ramadan, people cannot drink or eat during the day, so that really affected their bathroom habits. And certain cultures have different sanitary practices, which also can be a barrier to getting drug tested. I had to work in a team. I was working with a couple other coworkers every day, trying to work together to get people in and out of the clinic, to make sure that we were doing a good, high-quality job. Increase in confidence and speed. I was able to be really fast at my drug testing, getting people in and out of the clinic, and I gained reliability through repetition. We had to interact with professionals, like our partners, creating good relationships with them. Problem solving, like I said, efficiency and speed. Testing each individual comes with a different set of patients, a different set of communication skills. And then information literacy skills. There was a lot of testing processes and variations. There's a lot of certifications and hours that are necessary to run Department of Transportation testing. And then how do I see myself fitting in the field? I feel really passionate about disparities in information literacy. This is a huge area that's being missed in the healthcare system, and I would love to be able to go into those communities and be able to look at potential risk factors and barriers to health. ACEs, or adverse childhood experiences, is something that is becoming increasingly more popular within the U.S. It's the study of childhood experiences that can be potentially traumatic. And I would love to be able to work on as a case manager or collaborate about preventative measures. Addiction services is something that I feel very passionate about. I want to be able to be a person to run towards the people who are not being seen by others, just like Galatians 6:2 said, is to carry each other's burdens. Thanks.
And we'll open it up for questions of all of our presenters at the end of the presentation. Next up, we have Abby, who is also a community health major.
All right. Hello, everyone. My name is Abby, and like my fellow classmates, I reached the end of the Health Endorsement program. I'm a community health major and a psychology minor, so a lot of my time here at Bethel has been spent studying health. In one area I've had the chance to learn about closely inside and outside the classroom is mental health. I did my internship at the Ramsey County Children's Mental Health Collaborative, so I'm going to largely talk about my experience there and some broader healthcare outcomes I drew from that. So again, the Ramsey County Children's Mental Health Collaborative is an organization based in St. Paul, and like the name suggests, their aim is to support children's mental health through working with youth and their families. Their mission states that they work across systems to meet the complex needs of youth with mental health disorders and their families. So they largely serve children, youth, teens, and young adults 0 to 24 years old living in Ramsey County or attending a school in Ramsey County, as well as their parents and their families. And like their mission states, they truly work across systems in their services. They offer case management, social work, and overall serve as a personal advocate for the children and families that come to them. They offer many trainings on both everyday and complex life situations. They offer weekly family events, and they have a pretty extensive online bulletin board. So my internship, I was a community health intern through Bethel and a vaccine ambassador through Interfaith Youth Corps. And at the time of my internship, COVID wasn't new, but the vaccine was fairly new. So my team and I served as a resource for families to ask questions and find support. So we did a lot of identifying and compiling research on different protocols and forms of support for the families, and we'd give presentations, we'd have scripts, trivia games, pamphlets, however we could sort of express that information across, and we'd also help with coordinating transportation to families that needed it. I also helped a little bit with case management. The official definition right here says that case managers help children and their families obtain and coordinate therapeutic and supportive services that address the child's mental health issues and related social, recreational, health, educational, and vocational needs. So this could look pretty different for person to person. For me, what I did was reach out to a group of youth each week and just see how they were doing and if I could connect them to any resources or support. And sometimes people would need help, others would just need someone to listen to them, and sometimes people wouldn't need anything at all. So it could really vary. There also were weekly family events that I would sort of help out with, like art therapy, trivia, bingo, yoga, things like that, and then also supply deliveries. Most of the stuff was virtual during my internship, so for all of these events, we'd have to bring the supplies to their house. So I actually enjoyed it because it was the few chances I could get to actually see the families in person. So one aspect I saw my internship intersect with my course curriculum is through the social determinants of health. The official definition is the conditions and the environment so people are born, live, learn, work, play, worship, and age that affect a range of health functioning and quality of life outcomes. So it's mainly the aspects of your life that affect your health outside of your health directly, and they really inform us how complex and interconnected health is with pretty much every aspect of our life. The different categories are economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and your social and community context. And you can sort of branch out pretty far from there, but when it comes to addressing mental health needs, it's important to take the time to look through the perspective of systems and how people are being affected by it rather than solely a medical lens right away. And I think the social determinants of health really show that. So through connecting with the families and doing some research on the broader community that they live in, I got to sort of have a deeper perspective on how they're being affected by these. So it was really a strong lesson for me on how social determinants are strong indicators of healthcare outcomes, and how, because of that, that requires a very open mind to come in if you're trying to address how to help, and to make sure you're also looking outside of a medical lens. So one category of social determinants are location, and when you look at Ramsey County, where the collaborative serves, it is the county with the highest rate of serious crime. And this was the most recent crime study I could find, but that's according to 2018. Many of the families we served had lost a loved one to gun violence or other related forms of violence. In terms of location and its correlation to access to resources, Ramsey County has one of the lowest ratios between mental health providers to the population. 17% of Ramsey County youth live in poverty, as compared to the Minnesota average of 11%, and about 100 out of the 904 youth that they survey annually reported that they were homeless. So it's clear that there's a lot in relation to location. Looking at societal determinants, before the pandemic, many kids were receiving their mental health services from school, but with distance learning, that sort of disrupted a lot of systems there. So a lot of kids were facing isolation through that. And this same survey also indicated that per month, about most of the kids went 5 days or less engaging with other youth, and about 179 went 0 days talking to other youth on average per month. So it's evident that children are facing many challenges that contribute to their mental health outside of their health, and it's important to look at the individuals and the system surrounding them. Outside of direct therapeutic treatment, a lot of the needs that people need have to do with education or housing, transportation, things of that sort. So I learned that we're not only treating the illness, but we're treating and fighting the systems and the circumstances that allow it to keep happening. So as I sort of reflect on my takeaways from the internship and the broader healthcare implications, I think it's important to look at the climate of mental health nationally. So as we see up here, about 1 in 5 U.S. adults experience mental illness, about 1 in 20 U.S. adults experience serious mental illness, and about 70% of youth 6 to 7 years old experience a mental health disorder. So this is according to the National Alliance on Mental Illness, according to 2023 data. So I think these numbers really frame the health issue that is the mental health issue that is across the country, and how we can't ignore it and how they'll continue to rise. When I consider the future of healthcare in the realm of mental health, I think accessibility to services is a large issue that should be focused on, and I hope to help bridge those gaps someday. Therapist accessibility is a very prevalent issue today. According to the National Alliance on Mental Illness, about 1 in 5 U.S. adults experience mental illness each year, but less than half of them receive treatment. And about 55% of U.S. counties do not have a single practicing psychiatrist. So moving forward, it's important that we not only enhance the quality of the services that we're providing, but increasing the access that people have to them. There are many mental health providers, but there's also a really large population, and the ratio is just very small right now, and a lot of mental health providers are feeling it specifically, and it can be really hard to get the help that you need. I know here at Bethel, sometimes getting an appointment in the counseling office can be really hard, with it booked for like weeks and months. And I remember at the time of my internship, they had received a 300% increase in their services. So the service providers are really feeling it right now in the system, and it's important that the system that's put in place to support those with mental health struggles are also being supported in themselves. It's important to ask how we can help service providers and increase the number of people who want to enter these fields. So it's very humbling, but also overwhelming to consider the gravity of the issue and how systemic it is. And I've definitely felt like sometimes I was in over my head thinking about how I can't change a whole healthcare system or change a community or fix the issues that are at the root of what these families are facing. But I think the most important thing I learned is to think big, but also acknowledge the importance of trying to create change in the spaces that we can, even if it's small. We really owe it to ourselves and the future generations to keep working towards battling the multitude of issues that impact mental health of millions of Americans. I think that health is a system, and through healing one part, we can heal all. Thank you.
All right. And our last two presenters, Natalie and Mikayla, are both biokinetics majors.
Awesome. So my name is Natalie Arntson.
My name is Mikayla Turek.
And we are just going to present on our research that we completed as a part of our requirement for both our major and kind of how it relates to the future of healthcare in terms of physical therapy. So this is just kind of our general outline. We're going to go over some background information, some previous research studies that have been done, talk about our research question, our methods, go over our statistical analysis, results and conclusion, and really just driving at the end our future application for physical therapy. So our biggest thing was looking at something that applies to what we want to do in the future. And so we took a look at this new foundational study called the Postural Restoration Institute and their techniques in terms of analyzing and understanding asymmetries within the body. So this foundation was created in 2000, but it's really just kind of sprung up and become one of the new foundations for healthcare. And they understand the aspect of imbalances. They talk about the dominant overuse of right to left side asymmetries. And they talk about how there's no such thing as a normal in terms of how we understand alignment within our bodies. And we wanted to look at also the aspect of gait, which is understanding a walking pattern, and see how those two can align with each other. So diving into some previous research, we wanted to see how can we make this study reliable and accurate, as this is the first study of its kind. So we looked at different types of analysis, binary and qualitative, focusing on slow-moving segments, and decided that we were going to look at gait in terms of video analysis.
So kind of looking at the same thing, something that we used was a program called Canovia. So for the gait portion, we had a camera in the front and then on the side as well. And it would record the people walking, and we wanted to make sure that that program was also reliable. So we did actually look at some of the research, and lo and behold, there is a full study to see if it is reliable. And as you can see in the results section, there's a couple of reliability tests that was done on it. And basically all it says is that after the study was done, we did find that it was valid and it was reliable from all four perspectives, even though us two, we were only doing two of them. So our main research question was basically, is your standard gait pattern influenced by your classification pattern of asymmetry as stated by PRI? So methods is just how we got people to come in and do our research study for them. So we had subject recruitment. First of all, it was just word of mouth or emailing people, however we could get people to be interested in our study. Natalie and I do have some good connections. I'm in track, she's in volleyball, so we had a pretty large athletic population in there. Methods, the appointment was about 30 to 45 minutes long tops. First, we would have them go through the PRI segment. That is where our professor, Dr. J, would take them through the PRI segment since she is certified in that. Every single person was gone through her. And then after that, we would do the gait analysis section. And then after that, when they were done, we would do the video analysis by ourselves. Our methods of inclusion and exclusion, it was ages 18 through 24, people at Bethel University, and it was essentially, did they have informed consent, have their health history form filled out, and physically able to do the study and willing. For our methods of figuring out what we thought was going to be the most common pattern, as you can see with the little star in the top right, the left AIC pattern is what we thought was going to be the most common in people. And basically why we thought that is because the most common thing that we see is that the left hip is like tilted forward anteriorly. So because of that, that would be the classification. And Canovia breakdown for us. So as you can see, there are 4 different things that we were looking at through Canovia: stance time, stride length, width of base of support, and lateral sway, looking at the 2 planes of motion that we had video recorded.
Yeah, so diving into our statistics. So because the PRI assessment, which we haven't really gone over fully, but there was a series of tests that you would do to test upper and lower quarter, which are broken down, and then you are classified in a specific pattern. From there, that analysis would give you a specific tendency of alignment in terms of if you were, like we said, the left AIC, the pelvis tipped to the left slightly. If you had a posterior pattern, there would be some indifference between your pelvis and lower trunk. And then we looked at brachial chain pattern as well, which was talking about kind of our front side and looking at actually respiration and how that affects your movement. But we looked at a bunch of different things. So looking at range of motion in degrees, looking from right to left side, like we talked about in our study, identifying that pattern, and then those individual components of gait, like the stance time, stride length, and width of the base of support. We ran a correlational analysis from that, looking at all of the PRI aspects along with the gait aspects. We ended up doing a Tukey post hoc analysis, which is a fancy way of saying a lot of stats to figure out our groupings from upper and lower trunk. And we ran an ANOVA test using the SPSS system to look at the various aspects of gait and see if there was any statistical significance. So these basically are showing the different tests and how we ended up classifying them into their patterns. This is our lower quadrant patterns, and these are the ones that we actually ended up using for all of our stats. It was really cool seeing our different patterns. These were the lower quarter breakdowns, seeing the left AIC patho, PEC patho, and PEC. And actually in our total population of the athletic realm, we ended up having a bunch of different patterns, which was really, really cool, with our end size being of 50 total students. So we ended up getting a lot of recruitment, and that was super exciting for this study. This is just kind of that post hoc analysis looking at the upper and lower quarter, and then talking about the neutrality. So that was our big thing too, like there's no such thing as a normal. And so our study kind of proved that, showing that only 6 to 12% of the total population fell within that quote unquote no pattern range. So results and conclusion. We found that there was significance within upper and lower quarters of the PRI in terms of all components of gait. We found that the gait parameters that were used to measure were found similar between all groupings of subjects upon the specific pattern classification. And the gait characteristics selected remain a constant variable despite the existence of particular patterns and the compensatory capabilities and pathological compensatory aspects. And so some limitations, obviously we're just students, so we're just kind of learning through the process, but we did do our best to maintain that validity and reliability with our cameras. Our professor doing the PRI testing helped hold some of that validity, but there is some terms of adaptation to patterns and can classify people in different ways.
So the big thing that we want to take away from this is the real world application. There's a couple of different things that we wanted to touch on. The first thing is, as we know right now, this was the first study of its kind. So it was helpful for us to kind of add to that knowledge base. There's a lot of research out there and we wanted to contribute to that. And then also finding gait to find correlations within the human posture patterns. It's very interesting to us. Both of us are going to go to grad school in the future for physical therapy. So understanding that and hopefully bringing that into our patients and understanding maybe what might be wrong and how that might change the way they are walking, or even, like we said, we have a pretty large track and volleyball group in there. And even something that I found interesting is there is specifically within the track community one type of pattern that was happening within them. So things like that was just very interesting. And then also the relationship between patterns of gait and PRI techniques, just having the strength of the gait test was really interesting. Again, there's been a lot of gait research, but not a lot of gait research in correlation with posture. So a lot of times when we're doing gait research or watching the gait research, they kind of assume that left and right is the same. So looking at the patterns and seeing if there's any differences is something that hasn't been touched on a lot.
Yeah. And I'm planning on going specifically into the realm of pediatric physical therapy. And I worked with children for my internship. And so seeing that aspect of like, how can I get a kiddo to do something I want them to do and analyze these patterns could be like life altering, in terms of understanding those patterns and like seeing how we can, apply this to the future realm of physical therapy. So yeah, that was our research and these are our references. Thank you.
All right, thank you all. I'm going to invite the presenters back up here and open this up to some question and answer from our audience. So anything that you would like to learn from them or about the health endorsement, please feel free to ask away.
So I have a lot of questions about the gait therapy, but I'm just curious. Broad question is, are there significant gender differences?
So we actually ended up having a total split between male and female population. There are some tendencies, especially within trunk, just because men tend to have a higher musculature. So we tend to see that a lot of men are characterized within the left AIC with certain pelvis tendencies and discrepancies versus women. But it can range depending on type of sport, type of like hobbies can change those patterns. But yeah, there's a little bit of difference between men and women. Yeah.
About the endorsement program, I don't know if it's called a program, how many extra credits does that add to your majors in order to add that into your degree?
I think it was 13. It was 4 classes, 4-class requirement. There's Intro to Healthcare Ethics, Internship, and I'm missing one. The project. Oh yeah, the project. Sorry. But yeah, it incorporates really well within any sort of healthcare major, so nursing majors, community health majors, pre-PA. It was really cool to hear about how it's able to be incorporated into science-based programs as well. But yeah, I think 12 to 13 credits.
And one thing I'll add to that is at the evening performance or presentations tonight, we've also got students from business, social work, and communication studies. So really what we've done is try to create a program that fits well with any major here at Bethel so that students can see how healthcare fits throughout their major plan that they have.
I also think like the cool part about this is like I just took Introduction to Healthcare. I dualed my credit for my bioethics because it's an ethics course in terms of bio, and so that counted for both my major and this. And then we used our internship credit and research class as well for it. So it really fits in any schedule. It makes it super flexible, and I thought it was a really cool way to stand out in terms of applying to grad schools as well in the future.
Mm-hmm.
Abby, you were working with youth and mental health, and from nursing, obviously, we have many concerns. Coming away from that experience, like, what do you think was probably the key opportunity, or is a missed opportunity that you feel like either as a system or as individuals we could step into? Not to put you on the spot.
Yeah, that's a big question. That's a big question.
Yeah, like just an opportunity that you noticed that you felt like this is an opportunity. Yeah.
I think, there's so many ways I feel like I could answer this. I think one of the biggest gaps I saw, I guess, was therapist compatibility, or like compatibility between like providers and like the patient, I guess you could say. When there's such low like availability already, it's hard to find someone that's like compatible with. So it's hard to address the issue of compatibility before we address like the shortage as well.
Yeah.
But I'd say that's probably one of the biggest things I saw.
Thank you.
Mm-hmm.
I did a lot of communication studies and gender studies courses, and I think stereotypes and like the conversation around it publicly is something that's really affecting mental health, especially within children.
About the mental health issue, said you only work with the youth, so is it more acceptable now for people to ask for help, for children or young adults to ask for help, because it's generational change? A lot of generations don't like to ask for help, and also culturally, there's certain cultures where it's considered poor form to ask.
Yeah.
Have you noticed that when you were looking at, working with that group, like, oh, this culture doesn't want to ask? How do you get them to ask? How do you get them to invest in that mental health?
Yeah, I feel like there definitely has been a change over time. Like, I think discussing mental health in general had a lot of stigma behind it previously, and I think it's still there, but I think now there's like an overwhelming support and awareness for mental health that sometimes balances it a little bit. But I think there definitely are some groups who are maybe more hesitant to discuss their mental health or more reserved, and I think the biggest thing is just being patient and assuring people like that being vulnerable is a strength and it's not a weakness. And I think getting help is more important than, it will just only better you to get help. So it's definitely hard to break across those barriers, but I think just really being patient and trying to understand, like, for some people discussing it is very vulnerable and it may be culturally like dismissed or not appropriate. So I guess it can really change a lot depending on the context, but I think just being patient has been one of the biggest things, and open-minded. But I didn't necessarily face a lot of drawbacks of people like not discussing their mental health, especially if they were there, like they really were seeking it. But in terms of like sparking conversation and getting deep, it could sometimes take a while with people, I realized. But I don't know if that answered your question, but
yeah. I think it was interesting in the junior social work students did a poster presentation out in the egg just an hour ago. And one of the students was talking about trauma and how trauma is related to mental health, which can be related to crime, right? And then they had this group that was working, the circle group, that was, if people were involved in the circle group, their chance of it was like 2% of having another crime. But we talked so much about how childhood trauma and mental health are connected, totally connected. We see that in nursing, we see that, it's just like, and so then childhood trauma, that may not come, like the child may not talk about that, right? It may not come out until there's a mental health issue. So I don't know, that's just something that's pretty.
You had in your
slide
I
missed it, Abby. I'm sorry. I'm going to. I'll watch it later.
Adverse childhood events, right?
Yeah, adverse childhood events.
Or yeah, that was yours.
That was me.
I remember thinking, I was like, oh
yeah.
There's huge stats on that.
Yeah, I think this is a number coming off the top of my head, but I think it's 61% of adults identify with at least one adverse child experience. Yeah.
Isn't that crazy?
Yeah.
Isn't that's such a high number? Huh. So that's also a place to work on, right? How to have that trauma.
Yeah. The CDC is currently putting a lot of funding into preventative measures for adverse childhood experiences. I don't know how it's going, but I know that they're doing it.
Well, it's important to work, right?
Yep.
I had a question for you about the languages. You said you were using Spanish a lot.
Yep.
I was wondering, I'm new to the area, so is Spanish, wouldn't have been my top pick for the most other languages?
Yeah.
English. Is there any other languages that you think you should learn for this area? Or?
So my clinic was in Spring Lake Park, which it doesn't really change much in terms of population. I'm not sure why the Spanish population was so heavy there. We worked a lot with Department of Transportation. I lost my train of thought. What was your initial question?
What other languages are
Oh, there's a presence of Somali population, the Asian population. I think also just like understanding cultures within the community that you're serving, especially at a drug testing facility where sanitary practices, bathroom habits, like Ramadan, they can't consume any food or liquids, so that really affects their ability to provide a sample. So I think just like being aware of the cultural people that can walk through your doors is going to be really important. But I would say a lot of people speak English. It's just very broken English. But Spanish was probably the most common, I would say.
All right, that does bring us to the end of our time today. I just want to say thank you to everybody for attending and supporting our students. And if you've got any questions, feel free to contact them or myself because we're more than happy to help you out. Thank you.